The content of this meeting is being sent to a third party.
ഓക്കെ, ഗോട്ട് ഇറ്റ്
Got
എന്ന്
it.
പറഞ്ഞ് ഞാൻ നോക്കാം. പിന്നെ ഞാൻ അതൊന്ന് ഇത് നോക്കാം. യൂട്യൂബിലോട്ട് പോയിട്ട് ക്ലോഹാർട്ടി വന്നിട്ടുണ്ട്. ഇപ്പൊ ഇതൊന്ന്
വരുന്നുണ്ടോ? അതിൽ കാണാമോ?
വരുന്നുണ്ട്. ഞാനത്
പക്ഷെ
ഗ്രൂപ്പിൽ ഷെയർ
വീഡിയോ
ചെയ്യാം. ഗ്രൂപ്പിൽ ഷെയർ
അൺഅവൈലബിൾ
ചെയ്യാം.
എന്തോ കാണും.
ദീപ, ഈ കാര്യം ഒന്ന് നമ്മുടെ സ്റ്റുഡൻസിന്റെ അടുത്ത് ഒന്ന് പറഞ്ഞു കൊടുക്കണേ, എങ്ങനെയാണെന്ന്. ഒരു പ്രാവശ്യം ചെയ്ത് അവർക്ക് മനസ്സിലാവും. ഓക്കെ, ഇങ്ങനെ ഒന്ന്
നെക്സ്റ്റ് ടൈം
പഠിപ്പിച്ചു
ഇതുപോലെ
കൊടുത്താൽ
തന്നെ ചെയ്യാം.
നെക്സ്റ്റ് ടൈം തൊട്ട്. കാരണം ഇത് ഓൾറെഡി റെക്കോർഡഡ് ഇൻ യൂട്യൂബ്. ഇത് നിങ്ങൾക്ക്
ഓക്കെ.
പിന്നെ വേണമെങ്കിൽ റെഫർ ചെയ്യാം. അതിനാണ്. ഓക്കെ. ആൾക്കാർ ചോദിക്കുന്നുണ്ട്, അതുകൊണ്ടാണ്.
ഷീജ മാഡം ഇങ്ങോട്ട് വരുന്ന പറഞ്ഞേ. ഞാനൊന്ന് വിളിച്ചു നോക്കട്ടെ.
ശരി ശരി ശരി, വിളിച്ചോ.
ആ ആ.
ഗുഡ് ഈവനിങ് പി എം സി സർ. മ്യൂട്ടഡ് ആണ് സർ. മ്യൂട്ട് ചെയ്തിരിക്കുകയാണ് സർ. പി എം സി സർ.
ഓക്കെ, ശരിയായില്ലേ?
അല്ല, ഹരിപ്രസാദ് സർ ഓക്കെ. പി എം സി സർ മ്യൂട്ടഡ് ആണ്. ഗുഡ് ഈവനിങ് പി എം സി സർ.
ഹലോ, ഗുഡ് ഈവനിങ്. കേൾക്കാമോ?
കേൾക്കുന്നുണ്ട് സർ.
ഇതിന് വേറെ കോളൊക്കെ വരുന്നതാണ്. ഇപ്പൊ വന്നില്ലേ കഴിക്കാൻ? പാല് കഴിക്കുമോ? ഞാൻ കേൾക്കുന്നു. മ്യൂട്ട് ചെയ്യാൻ നോക്കിയിട്ട് പറ്റുന്നില്ല. തുടങ്ങിയില്ല.
ദീപ മാഡം എത്തിയായിരുന്നോ? ഓക്കെ, അല്ലേ ഉണ്ട്. ഫൈൻ.
മാം എത്തിയിട്ടുണ്ട് സർ.
എത്തിയിട്ടുണ്ട്. ഞാനൊന്ന് നമുക്ക് പ്രൊസീഡിങ്സ് സ്റ്റാർട്ട് ചെയ്താലോ? അതിലൊരു വെൽക്കം എല്ലാവർക്കും പറയുന്നോ? അതോ
ഇല്ല.
ശരി, ഓക്കെ, ഫൈൻ. So good evening to one and all. We welcome all of you on behalf of KIMS Health, IAP and NF Trivandrum to yet another Cloherty Clinical Pulse, Evidence-Based Neonatology. It's our flagship program of my guru and my mentor, Naveen sir. And under his guidance, we are conducting our Cloherty Clinical Pulse very meticulously. And this is not only important for all our postgraduates, both in pediatrics as well as neonatology, but also for practicing pediatricians. It's being made very, it's been simplified for all. So without much delay, I would like to call upon our IAP Trivandrum President, Hariprasad sir, to speak a few words. Over to Hariprasad sir.
Okay, thank you, Derbeno. Dear and most respected teacher, PMC sir, and our own students, Dr. Deepa, Sheeja, and all other team members from KIMS, and all fellow pediatricians. I think the Cloherty series is a very, very innovative topic, innovative idea coming from none other than Dr. Amin, and I'm sure that this is going to create wonders in management of newborns. Okay, so and I'm really happy to hear from our own students, Sheeja as well as Deepa, and the proud moment of a teacher is to learn from his own students. So this is a great opportunity to learn from Sheeja and Deepa. So without wasting much time, I wish this program all the success, and over to Benno to continue the proceedings. Thank you.
Thank you, dear sir. Thank you, sir. So may I request our dear PMC sir to speak a few words before starting our session? PMC sir.
Sir, ഉണ്ടായിരുന്നല്ലോ.
Sir ഉണ്ടായിരുന്നു. എനിക്കൊന്ന് sir, okay, patient ആയിട്ട് busy ആണ്. Okay. Yeah. So I think sir is busy with sir is seeing, I think, patients.
Mute ആണ്. അതെ.
Okay. So without further delay, I think we will go on to the proceedings. Now I request moderator Sheeja madam. I am handing over the mic to Sheeja madam, and we will continue with our presentation. Over to Sheeja madam.
Thank you, Hariprasad sir and Dr. Benno, for the opportunity. I thank all of you for joining us this evening. Now, I don't think I need to elaborate much on the deleterious effect of hypoglycemia in a neonate. That is one of the dreaded problems that a neonatologist or a pediatrician is going to face. So it is very important that baby with hypoglycemia is properly managed, properly diagnosed and managed. And from an endocrinologist point of view, perspective, I consider diazoxide like something similar to insulin. What insulin does to a child with or a patient with diabetes. Diazoxide does that to a newborn or a child with congenital hyperinsulinism. Improves survival, prolongs life, and improves the quality of life, improving the neurodevelopmental outcome and cognition. Diazoxide was discovered, the hyperglycemic effect of diazoxide was first discovered in early 1960s. But still, even after so many decades, it still remains the only FDA-approved drug for congenital hyperinsulinism. So let's hear from Dr. Deepa about this miracle drug. Thank you.
Deepa, just before starting, I'll invite our next moderator, Sreekanth sir, and welcome sir. And sir is consultant neonatologist at RCPM Hospital.
Thank
Kollam.
you.
Yeah, welcome sir to our Cloherty clinical series.
Thank you.
So, thank you sir.
Yeah.
So over to Dr. Deepa for the proceedings, for the presentation.
Good evening, all who have joined this meeting. I'll straight go to the presentation. So, as Sheeja Madam has introduced, today's topic is about managing hypoglycemia in neonates and focusing on this drug called diazoxide. And regarding the topic of hypoglycemia, everyone is aware and we need not elaborate much regarding its importance as a neonate and on the long-term outcome of babies. And as pediatricians and neonatologists who are dealing with babies daily in NICUs as well as in the well baby wards and clinics, we are all sensitized regarding the importance of hypoglycemia. And as such, it is considered as a medical emergency in neonatology. And today's discussion will be focusing most on diazoxide. So regarding hypoglycemia pathogenesis, it is all about a balance between the hormones, insulin, and the other counter-regulatory hormones. And this happens as the baby switches to its postnatal life from the fetal life. And neurodevelopmental concerns need not be well elaborated. Regarding cognitive outcomes, visuomotor outcomes, and seizure disorders most commonly. And everybody is so concerned about this that various definitions have been proposed regarding what to define as hypoglycemia and where to act, at what threshold to act. So various bodies, including the AAP, the Pediatric Endocrinology Society, everybody has tried to define hypoglycemia. And there have been various studies regarding the etiology, the management, the investigations, and how to move about. And as I mentioned before, it is a switch from the fetal life to the postnatal life, and during which the baby itself has to adapt metabolically, balancing its various hormones and the energy fuels. So any imbalance happening during this period can lead to hypoglycemia. And regarding the topic of today's presentation, it's focusing on insulin. So insulin on one side and the other four hormones, mainly glucagon, epinephrine, and cortisol and growth hormone, working together in the glucose homeostasis. So that insulin is on one side, it being very potent. It alone manages to reduce the blood glucose, whereas the other four hormones try to counter-regulate it. So the etiology and management of hypoglycemia, the investigations all focus on whether insulin is increased or the other hormones are imbalanced or any other pathology. So hypoglycemia as such is broadly classified into hyperinsulinemic hypoglycemia as well as normoinsulinemic hypoglycemia. So our topic diazoxide is basically dealing with hyperinsulinemic hypoglycemia. Regarding this, I will just elaborate in detail regarding the physiology of insulin secretion. As we all know, insulin is produced from the beta cells of the islet of Langerhans. At the resting stage, how a beta cell functions, the main regulator is something called as the ATP sensitive potassium channels in the cell membrane of the beta cells. So inside the cells in the resting state, that is when intracellular glucose is not sufficient, the insulin is stored in granules, and the cell is in a hyperpolarized state due to the activity of this potassium channel. And when it is active, what it does is it transports the potassium ions outside so that the cell remains hyperpolarized. So the cell is in a resting state. And what happens when glucose enters the beta cells? So the entry of glucose into the beta cells is mediated by the transporter called as GLUT2, which is insulin independent. It is unlike any other glucose transporter in many other cells, which are insulin dependent. So when blood glucose levels increase, it enters the beta cells. And then as in any other cell, it goes on to the metabolic pathways, glycolysis and the Krebs cycle, then going on to electron transport chain, finally releasing ATP. So this ATP increase inside the cell triggers the closure of the ATP sensitive potassium channels. So what happens when these channels get closed is that the membrane gets depolarized. So as the membrane depolarized, the voltage gated calcium channels open and calcium enters intracellularly. So that again, what happens next is the release of insulin from the insulin granules. So that this whole pathway of insulin secretion is very tightly regulated according to the blood glucose levels.
ടാസ്ക് ആണ് ഇൻസുലിൻ സെക്രേഷൻ ഒക്കെ.
ഇപ്പൊ ഒന്ന് മ്യൂട്ട് ചെയ്യുന്നു എല്ലാരെയും, ഒന്ന് മ്യൂട്ട് ചെയ്താ. ദീപ ഒന്ന് അൺമ്യൂട്ട് ചെയ്യണേ. ദീപ മ്യൂട്ടഡ് ആണേ. ദീപ മ്യൂട്ടഡ്.
Okay. As the insulin secretion is very tightly controlled by various genes. As such, there are at least 11 genes currently being considered as significant in the insulin secreting pathway. So that much is the tight control in our body in this insulin secretion. But everything may not go all right all the time, especially in neonates who are born and who are born sick or preterm or with any other risk factors. So this is the basic pathogenesis behind hyperinsulinism, either because of the perinatal issues or because of any mutations in the various genes concerned. These babies can develop hyperinsulinism. So basically, the causes of hyperglycemia has been classified into hyperinsulinemic as well as normoinsulinemic. So in the hyperinsulinic type, the more common ones are the perinatal stress related. So by perinatal stress means any babies who were born with risk factors like an asphyxia or a baby with early onset sepsis, or babies who are born small for gestational age, babies whose mothers having diabetes or even gestational hypertension, babies who are born IUGR. Then if the mother is receiving more dextrose infusions during the delivery, all these babies are prone to get hyperinsulinism in the immediate perinatal period. So these are babies who are already having supposed risk factors for hypoglycemia. And even in seemingly well babies without any risk factors, sometimes hypoglycemia can present. And some of them may be genetic. Any mutations, as previously mentioned, can lead on to this monogenic hyperinsulinism. And rarely some syndromic causes like this Beckwith-Whitman syndrome, Costello's, Kabuki syndrome also can present with hyperinsulinemia. As such, classifying the etiologies, the perinatal ones are the common and the genetic ones are comparatively rare. So we have to understand that and in understanding and managing hypoglycemia in neonates, hyperinsulinemia is the commonest one, and that is the most significant and the severe one and more difficult to manage in NICUs. So the incidence of genetic hyperinsulinism is rare in that it's about 1 in 50,000 live births as per medical literature. And regarding the medical management of hyperinsulinemia, as it is a medical emergency, various drugs have been tried, and the most commonly used and the approved one is diazoxide. So today's discussion will be detailing about diazoxide. And as Madam has mentioned, this is the only drug currently approved by the FDA for hyperinsulinemic hypoglycemia. And as per various retrospective studies over the past decade, there has been some increasing use of diazoxide off-labelly in NICUs as such. And the diagnosis of hypoglycemia in neonates as well has increased, and the awareness has increased. The definitions have changed, the thresholds have changed, and various guidelines are there. So people are aware and people are managing aggressively, and as such, use of diazoxide also has increased as per literature. Regarding the history of the drug, as Madam has told before, this drug was not initially started for hypoglycemia. It was mainly for hypertensive emergencies as an IV formulation. It was brought out as a systemic vasodilator, specifically an arterial vasodilator. And during that use, it was noted to be diabetogenic. And the discovery was in the 1960s itself. And then the mechanism of action was suspected that it blocks the insulin release. And from there, it was extrapolated to the hypoglycemias in neonates. And the first documented use is in 1964 by Drash and Wolf. And they have tried using this in a case called leucine-sensitive hypoglycemia, where they have succeeded in giving this drug to a baby with refractory hypoglycemia. Following this, they have tried repeating this in a cohort of around 10 babies. All of them succeeded in improving the blood sugars. And following which other people have also tried using this in neonatal hypoglycemias. And in 1973, the drug got FDA approval. The chemical structure of the drug is that of a benzothiazine ring. This is a benzene ring with a two sulfide groups and a diazine groups. So this is called as benzothiazine by chemical structure. The specific mechanism of action is to inhibit the insulin secretion. And the site of action is particularly in the ATP-sensitive potassium channel, which is a major regulator of insulin secretion inside the pancreatic beta cells. So, elaborating on the structure of this ATP-sensitive potassium channel, it is an octameric structure. That is, 8 subunits are there with 4 outside and 4 inside. The outside subunits marked in red is the sulfonylurea receptor 1. And there are 4 of them. And inside one is the inwardly rectifying potassium channels, which transports the potassium causing hyperpolarization. So these 2 subunits are coded by specific genes, which are often mutated in the hyperinsulinism scene. So this sulfonylurea 1 subunit is coded by the ABCC8 gene, and the potassium inwardly rectifying channel, that is coded by the KCNJ11 gene. So our drug diazoxide action is specifically on the sulfonylurea receptor 1 subunit. So what happens exactly when the drug binds to the subunit? The channel remains open. So that is the channel's activated stage. So the hyperpolarization continues and the calcium secretion is calcium entry is inhibited, so that the insulin is not at all released, even if the blood glucose levels are high. So the site of action is at the ATP channel, which is the major regulator. So that is how the diazoxide is able to act in many cases of hyperinsulinism, even if it is the uncontrolled perinatal stress related, or many of the genetic forms also, where the different genes are mutated. But some of the, like in the genetic forms, the commonest one being the mutations in the ATP channel itself. So where the channel itself is not functioning, diazoxide may not be able to act. So understanding the site of diazoxide action is important. It may not work for all cases. And we have to understand that this ATP sensitive potassium channel is not only present in beta cells, it is present in other cells of the body, especially in the cardiovascular system. It is present in the cardiac muscles and the vascular smooth muscles, and even in the skeletal muscles, brain, skin, everywhere it is present. So it is useful in hypertensive emergencies because it is causing arterial dilatation. Likewise, it has got its effects on other organs of the body also. Regarding the kinetics of the drug, the T half is documented to be around 15 to 20 hours. And the time to achieve a steady state concentration is around 5 times of this. So around 72 to 96 hours, that is 3 to 4 days. So to get a clinical response regarding the blood glucose levels, it may take even 2 to 4 days. And the drug is also highly bound to plasma proteins and excreted through the kidneys. And regarding the dosing of the drug, similar blood concentrations has been achieved with twice daily or thrice daily doses. So either dosing interval is equally effective clinically. And what all formulations are available for us currently? We get it as capsules of 25 milligram, and some tablets of 50 milligram is also being described, and some internationally the suspension 50 milligram per ml is available. So FDA, this is FDA approved drug, but the indications are specifically only for islet cell hyperplasia, islet cell adenomas, extrahepatic insulinomas, and leucine sensitivity. But off-label, this has been used in all cases of hyperinsulinism. Currently, this in neonatology, this is considered as the first line treatment for refractory and persistent hypoglycemia due to hyperinsulinism. And before initiating this drug, it has to be hyperinsulinism. So that has to be confirmed. So when a baby presents to us with hypoglycemia requiring dextrose infusions, if it is hyperinsulinism, typically the dextrose infusions are usually very high. Being described is more than 10, but even it goes to 15 and 20 mostly. And whenever we try to taper the dextrose infusions, baby goes to hypoglycemia. And many of these babies are seen to be mostly demanding more for feeds, and they are always very hungry. And regarding the etiology of hyperinsulinism, we may get some clues from the history itself. For example, we have to see the perinatal risk factors, as mentioned before, whether the mother had any risk factors like diabetes or hypertension, and how the baby's birth weight is, and with other perinatal risk factors like asphyxia, sepsis, etc. And examining the baby is also important, like features of intrauterine growth restrictions, any syndromic features, for example, our Beckwith-Midman with macrosomia and congenital anomalies, any dysmorphic features like in Kabuki syndrome. So these will give a clinical clue. And sometimes a family history may also be positive in case of genetic mutations, even though some of them are sporadic. And confirming this hyperinsulinism by a lab test is very important before starting the drug. It has to be hyperinsulinism. So the critical sample is taken when a plasma glucose is below 50. And any detectable insulin during that hypoglycemic episode is indicative of hyperinsulinism, along with the low documented levels of ketone bodies and free fatty acids in the blood. And correspondingly, other etiologies has also to be ruled out, like a metabolic disorder. So blood gas, ammonia, and lactate is indicated. And also other hormone deficiencies like cortisol deficiency and growth hormone deficiency are also to be ruled out before confirming the hyperinsulinism. And also an exaggerated response to a glucagon dose, that is also said to be pathognomonic of hyperinsulinism. Rise of blood glucose of more than 30 after a glucagon administration is also significant. And after confirming hyperinsulinism, starting on diazoxide will depend on the presumed etiology and the setting of the hypoglycemia. Many of the transient hyperinsulinism cases, they may resolve by themselves over a few days. But here we have to weigh the balance between continuing a dextrose infusion in an NICU and counseling the parents regarding the etiologies and the further management. So clinicians can decide on whether to wait and or whether to start it early. And the response to diazoxide depends on the pathology also. As I have mentioned before, all the transient types, they respond to diazoxide quickly, while the genetic types depends on what mutation it is. So the commonest mutations being the ATP channel disorder, so they may not respond to diazoxide. And regarding, it depends on the what mutation also, whether the all the beta cells are involved, like it is if it is a diffuse form or it is a focal form. If it is a focal form, it is usually unresponsive to diazoxide, whereas a diffuse form may respond to diazoxide or may not respond. And revisiting this figure once again, if it is a mutation in the ATP channel, this channel is not present there, then diazoxide may not act. If it is a mutation in any of the upward pathway genes, diazoxide will be acting. So regarding the setting, we can presume whether baby may respond to diazoxide or not. So after initiating the drug, again, we can decide whether to send the genetic mutation. It depends on the clinical response. And the Endocrine Society working groups have defined diazoxide responsiveness as to wait for at least 5 days of diazoxide with a maximum dose of 15 mg per kg per day before labeling it as a non-responsive case. And in cases of non-responsiveness, it is the ATP channel mutation commonly. So then a genetic analysis is indicated to define which mutation it is and if it is autosomal dominant or recessive. And a PET scan of the pancreas will also help whether it is focal or diffuse. So this will decide regarding the further management, whether to go on with medical management, whether to try other drugs or to go on surgically. So specifically, the PET scan will distinguish between focal pathology or diffuse one. If it is a focal pathology, it is mostly associated with the dominant autosomal dominant mutations inherited from the father, associated with the maternal allelic loss in the somatic cells. So that such pathologies may respond to a partial resection of the focus. So this is a picture showing the PET scan. And as neonatologists, our safety of our babies are most important to us. So before initiating the drug, we have to be thorough with how to monitor regarding this drug. And literature has described many cautions regarding the use of diazoxide in the NICUs. Some of them have even described it as the danger of diazoxide in the NICUs. So caution is there, of course. And recently, some studies are there. Mainly, these are all retrospective cohorts and case reports and case series involving small sample sizes. As such, this hyperinsulinism is compared to the other comorbidities, this is a comparatively rarer one. So prospective study and RCT are not always possible. So most of the evidence is based on retrospective studies. And the most serious side effect being reported is pulmonary hypertension, and other common side effects being fluid retention, even causing edema, and in preterm babies, causing reopening of our ductus or even congestive cardiac failure. Then hematologic effects like cytopenias are documented. Then metabolic effects like hyperuricemia, hyperglycemias are also reported. And of course, this hypertrichosis is a commonly reported one with long-term use. I'll just elaborate regarding this pathogenesis of pulmonary hypertension. And this is especially important in other settings of pulmonary hypertension, not in well babies who are otherwise started on diazoxide. Those babies who have a setting for pulmonary hypertension, for example, those born with asphyxia, meconium aspiration, or those born with a respiratory distress syndrome, as in a premature baby, or an SGA baby, even due to placental insufficiency, this lung growth may not be adequate. So those babies, if we are again, these babies themselves are prone for hypoglycemia. So in such a setting, if we are starting on this drug, we have to be more watchful. So pulmonary hypertension cases are all being reported in this setting. So the presumed pathology is a dysfunction in the nitric oxide synthase in the pulmonary vascular endothelium. So this has been proven with some animal studies. And this drug also causes an effect of sodium and fluid retention. So this was important in managing our preterm babies. Reopening of a PDA in such a preterm baby will be management wise, everything will change. And literature has described many of these babies going on to higher respiratory supports. The incidence of pulmonary hypertension generally has been about 2 to 7% only. But in targeted populations involving the preterm babies and these SGA babies, it has been described as high as 50% in this retrospective study by Desai. They have described this as 50% incidence. Their mean gestation was 33 weeks and mean birth weight was 1.7 kilos. So out of these 15 babies, they have reported adverse effects in around 8 babies, and 5 of them developing pulmonary hypertension, which is echo confirmed, and 2 of them requiring even inhaled nitric oxide for this pulmonary hypertension, and 6 of them developing respiratory failure requiring higher supports. So it depends on in what population we are using this drug. And based on the similar studies coming out, this FDA has given a black box warning in 2015 for the use of diazoxide in neonatology. So various working groups have considered the safe use of this drug, and endocrinologists and neonatologists, some studies are there recommending thiazide diuretic starting along with the starting of diazoxide and using a baseline echo before starting and repeating an echo 1 week later to monitor for pulmonary hypertension if we are starting diazoxide in this setting of pulmonary hypertension. And other caution is with hematology. Cytopenias have been described in around 15% of cases in retrospective studies, mainly neutropenias and thrombocytopenias. But clinical significance of this is rather unknown. The increased susceptibility to infections or bleeding manifestations are not described in literature. And people have advised doing a baseline CBC before starting to be safe, to be on the safe side, and repeating it 1 week later and continuing 3 to 6 monthly if the baby is continued on diazoxide. Other important issue described in preterm babies is NEC. And this has been variable incidence and low incidence only, especially more in this FGR babies after starting the drug in the first week of life. And with long-term use, GI side effects like vomiting, diarrhea are also being reported. Metabolic effects like hyperuricemia, it is advised to do a baseline uric acid levels and to repeat it 1 week later and to monitor it 6 monthly. And if the baby is on higher doses of diazoxide on the upper limits, they are more prone for hyperglycemias also. And regarding hypertrichosis, it is a commonly reported side effects in literature with long-term use. And the hair growth has been reported on forehead, back, and limbs of the babies with long-term use. So it is thought to act on the potassium channels in the skin. And some case reports are there with abnormal facial features also. 2-3 case reports I could see regarding the acute nephritic syndrome in neonates with the start of diazoxide, but all got reversed after discontinuing the drug. And one Indian study is in 2018 by Balachandran et al. With 30 neonates, small for gestational age, 32 weeks and more. They have tried randomizing these babies into two groups. One group starting with early diazoxide within first 5 days of life. So they could reduce the dextrose infusions significantly with the use of this drug. But in this study, there were no adverse reactions. And summarizing all the evidence from literature available, the working group from our pediatric endocrine societies have suggested use of the recommendations regarding the use of this drug as a transient hyperinsulinism cases. That is the majority of the cases in NICUs, and weighing the risk versus benefit, because this diazoxide is to be used cautiously. So they have suggested waiting for 7 to 10 days if the GIR is manageable. That is, if we are able to manage in using our central lines and the babies is responding to that, we can wait for maybe 1 week before starting the drug. And consultation with the pediatric endocrinologist is desirable in the workup and management. Regarding the dosing, 5 to 15 milligram per kg per day. Starting dose depends on our presumed etiology and other risk factors. So if it is a perinatal stress type or if it is setting for pulmonary hypertension, we can start on low doses and titrate it according to the glucose response. But we have to remember that it may take 4 to 5 days to reach a steady state concentration and to show a positive response. So based on the blood glucose levels, we can increase this dose by 2 to 5 mg per kg per day. And prior to starting, of course, we have to assess the cardiopulmonary status of the child and may do a baseline echo also. We can consider a thiazide diuretic, and of course, fluid restriction is advised. And we have to monitor the baby's fluid status, cardiovascular and respiratory status, and consider a review echo. And blood counts and serum uric acid is advised. If the baby is responding to diazoxide, we can, if the blood glucose levels are maintained at least 70 milligram per deciliter, we can consider decreasing the dose every 2 to 4 weekly. So once we have tried to below 5 milligram per kg per day, then the taper has to be slower by 1 milligram per kg per day. And after we have stopped diazoxide, it is better to monitor the baby in hospital for 5 days, and a fasting test is also sometimes advised. Also, as neonatologists, our baby's outcomes are also very important for us. And outcomes also depend on what pathology it is, whether it is transient one or a genetic one, and which mutation it is. And depending on what management we have given, if we have gone for a pancreatectomy, some babies may be prone for hyperglycemia and diabetes. And some mutations like the HNF4A mutations, they are more prone for maturity onset diabetes in the adolescent period. If we have done pancreatectomy, exocrine pancreatic insufficiencies may also manifest. And of course, neurodevelopment is the most important one. And all hyperinsulinism cases are to be followed by a formal developmental test periodically. Because as we know, hyperinsulinism is not only with hypoglycemia, it will prevent the utilization of other metabolic fuels also. For example, our ketone bodies, lactate. The brain is devoid of these metabolic fuels also. So if it is hyperinsulinism, the brain is more prone for energy failure and cognitive outcomes are guarded. So we have to be managing it aggressively as well as we have to be following it up strictly. So summarizing what I have told now regarding diazoxide, it is a drug where we have to balance in each case the risk versus benefit ratio. Key points from today's presentation. Diazoxide response is excellent in most of the cases of hyperinsulinic hypoglycemia, especially in the transient forms. And but some genetic forms are unresponsive. Whatever evidences we have currently are based on retrospective studies and expert consensus. Our NICU babies who are having hypoglycemia, they have other comorbidities also. And we have to be watchful before starting the drug as well as monitoring the baby. Our starting dose of diazoxide is based on what etiology and what risk setting the baby is. That's all regarding my presentation for today. Over to you, ma'am.
Thank you, Dr. Deepa. Deepa has given us a pretty comprehensive overview on diazoxide. Excellent presentation. Now, I'd just like to make a few comments, couple of comments. First is about hyperinsulinism. Hypoglycemia, when it becomes recurrent and persistent, the first step would be to see if it is due to hyperinsulinism. And how do we do that? We can send for a critical sample analysis. And if you find a detectable insulin level, that indicates hyperinsulinism. But equally important would be to see how the ketone levels are. Because ketones will be absent in hyperinsulinemic hypoglycemia. So very important step. Some labs, the insulin levels may not be that reliable. So checking how the ketone level is important. Now, once we've made a diagnosis of hyperinsulinemic hypoglycemia, next step would be to see whether it is diazoxide responsive. If it is responsive, we just need to continue that. Even the genetic test is not mandatory. But if it is unresponsive, then in order to proceed, we have to do the genetic study and then go ahead with the imaging, the F-Dopa PET scan, to see if it is a focal. This is because focal, the surgical treatment is curative. And yes, that is all about hyperinsulinism. Now, about diazoxide, we have been using it for the last 10 years or more, about 10 years. And before it was not that easily available, but nowadays we get it everywhere. What we have available now is by the Belila by Jolly Pharma, and there is the Proglycem, the suspension form, which is also available. So we have, it is a rare condition. We have a few children who are doing well on diazoxide responsive children. And about the side effects, hypertrichosis is very common, but that is dose dependent. As Dr. Deepa has mentioned, as we come down on the dose, we see it disappearing. And the most dreaded side effect of pulmonary hypertension, I have not come across any. I'd like to hear from seniors. But maybe in high risk babies, it is definitely important to do a preliminary cardiac evaluation and start diuretic along with the diazoxide. Now, I'd like to hear comments from PM sir. Sir, please. Dr. Sreekanth.
I have muted it anyway. So for me, diazoxide, when we are working, it is not available. We used to get it from Ernakulam One Center, and I used to keep it in the refrigerator in SAT hospital, because suddenly in the middle of the night, one baby comes with a blood sugar 0 and all, we used to keep it as an emergency use. So I don't have any experience with PPHN and electrolyte disturbances with diazoxide. Anyway, it is a good presentation. It is completely covering all the important aspects. Thank you.
Sreekanth sir, can you please elaborate on our neonatologist perspective?
Yeah, Deepa on the screen sharing stop yamo.
Good evening all. Thank you for the excellent presentation by Dr. Deepa. So can you hear?
Yes, sir.
Yes, sir. Yes, sir. Audible, sir.
Yeah, it was very elaborative on diazoxide. So as ma'am has already told, we are very well, as neonatologists, we are very much concerned about the neurodevelopmental outcomes of the baby. So the neurodevelopmental outcomes as related to the duration of hypoglycemia also. As the prolonged hypoglycemic duration is prolonged, the neurodevelopmental outcomes becomes worse. So diazoxide is a wonderful drug. It helps us in decreasing the duration of hypoglycemia. So another thing is it helps in it is a therapeutic as well as a diagnostic drug. So if it is not responding to diazoxide, it means it has some genetic etiology. So we have to do further testings and genetic mutation testing. Another thing I want to elaborate is like it is actually a diazoxide is we can give orally, so we are able to get out of the lines as early as possible. That is one good thing about diazoxide. And most of the hypoglycemias what we encounter in our practice is transient. We are able to get out of the diazoxide by around 1 month. So what we usually do is we start diazoxide. At times we used to add octreotide initially to get hold of the sugar levels. Then slowly we taper out octreotide, and then we on the diazoxide we discharge the patients after 2 to 3 weeks, like tapering what you told. So actually, as the baby's weight gains, the tapering it starts automatically. So as the weight gains, the milligram per kg decreases. So when it becomes 2 to 3 weeks, we just call them, admit them for 3-4 days, and stop the diazoxide, monitor the sugars, and then discharge. Most of them get out by 1 month. And regarding the safety and side effects, usually we don't regularly add hydrochlorothiazide. We monitor the weight for the weight gain and serum electrolytes. So if hyponatremia is there and fluid retention is there, then we add hydrochlorothiazide. That also we usually give for 3-4 days and then stop. So we need not give it for all the days, along with the diazoxide, what I think. And as you mentioned, the neurodevelopmental outcome may be varied. So we need to have a close follow-up of this all patients with hyperinsulinemia. Thank you.
Regarding diazoxide, here also we usually don't initiate on this thiazide electively. It depends on the clinical setting already mostly. And follow-up is also similar, what we used to do here. And regarding the adverse reactions, maybe in preterm babies we may encounter, but I have not seen further regarding this pulmonary hypertension.
We have not also seen pulmonary hypertension. The common side effect we see is like some fluid retention, some edema. So
Yes.
that also gets cleared off initially.
Yeah. May I invite Naveen sir, for sir's inputs? Naveen sir. Yes.
It was very nice to hear Deepa. Actually, we had heard her, and the presentation is very, very immaculate. And I will go with both Sheeja and Sreekanth. Thank you, Sreekanth, because many of the side effects which are described, like pulmonary hypertension, could possibly be incidental findings, because at least half of the babies who are going to be initiated on diazoxide are secondary to multiple insults like asphyxia, sepsis, and things like that. And it may be impossible to tease out the side effects of diazoxide versus a baby who is already having proneness for pulmonary hypertension. Don't have too much experience, but maybe I can recall 15 babies maximum who we have given in last 25 years. And at least half of them were not based on a very scientific approach like Deepa presented. We like Sreekanth said, or like others, PMCs have said, when we are desperate that hypoglycemia is not getting better. Octreotide seems to work like magic immediately. So sometimes we'll end up using that before we use diazoxide, not by any science, but by desperation. But there are babies who have done well with diazoxide and gone home. Long-term side effects are not there. But I think it is a good opportunity for all of us, maybe under guidance of Sheeja and maybe Deepa. We can go back to our records and look at something like 20-25 babies together who we have used diazoxide and rewrite the side effects that we have seen in a setting where comorbidities were not there. And many of these side effects comes from very small case reports. They keep on getting cited all over again. I can only mention that one article came in on diazoxide which very clearly appeals to pediatrician neonatologists that it's an underutilized drug. and that the fear of side effects has kept and non-availability has kept this drug away in rescuing babies who may be having hyperinsulinemia. And like Deepa said, it is the secondary ones who may respond very quickly, and therefore it should be a drug which most of us should have, and probably we'll learn together. Thank you, Deepa, and thank you, Benna. Back to you.
Thank you so much, sir. May I request Shobha madam to give madam's inputs.
Good evening to all. As Sir has mentioned, the availability was our main issue. It was not licensed to be marketed in Kerala, so we used to get from Nagarkoil and all, and patients also were not ready to buy it because of the cost. For the past 2-3 years, we are getting by the scheme also, and it is to we have to go to the pharmacy and powder it. And as Deepa has mentioned, it is a good drug for LGA babies, hyperinsulinism, where we can give orally. But our problem comes, most of our babies are IUGR babies and cannot be started on feeds very early. So in those babies, it is very difficult to give the first option as diazoxide. And as Dr. Sreekanth has mentioned, we usually go for octreotide first, and when the baby can be put on feeds, minimum feeds at least, then only we can start on diazoxide. The second point is many babies have even otherwise some amount of pulmonary hypertension if you do, and I have not seen a side effect of pulmonary hypertension as a part of diazoxide. And most of the babies can be withdrawn before they get discharged from the hospital, and only few babies, 2 or 3, are followed up in the endocrine clinic. The availability is a very good blessing for the neonatal unit, but the administration is difficult in IUGR babies, where we go for octreotide now also, and then when the feed is full or increasing, we will be starting on diazoxide. Thank you.
Thank you, madam. Jyoti madam's inputs. Jyoti madam. I think madam is busy. Now I call upon Femita ma'am.
Hi, Beno. Nothing to add, Beno. We must
Okay.
have seen a few flushing and fever and a bit of fluid retention. That's it. Otherwise, safe drug.
Thank you, ma'am. I still remember calling up Sheeja madam during my initial days of joining Cosmo, when there were this hypoglycemic children. So ma'am used to advise me to send these lab such as insulin, cortisol, and lab RBS. So we used to do that, and I still remember ma'am initially teaching me how do we detect, when do we start this diazoxide. So I think we started off at 5 mg per kg per dose initially, and then gradually we tapered as per the response. That's what I think what I used to do previously. And we used to get, and as Shobha madam said, hypertension, I could not find any babies on as hypertension as a complication on starting diazoxide, and had to continue probably for around 7 to 8 days, and then gradually discharge the baby off diazoxide. That was the experience in Cosmo. Any other questions from the audience side? Anything Sheeja madam wants to add? Muted, madam. Muted, madam.
That's nothing more to add.
Okay. So Deepa, we'll wind up, sir. Yeah. So first and foremost, I would like to thank our speaker, Dr. Deepa James, for an excellent presentation, and had done a very good homework regarding the presentation and has presented very well. And special thanks to our moderators, Dr. Sreekanth. Thank you, sir. In spite of his busy schedule, has agreed to join us. And of course, our dear Sheeja madam, who had explained to us all the facts very wonderfully and made things easier for us. And next, I would like to thank our beloved PMC sir for giving us valuable inputs and for joining us today. Next, I would like to thank my teacher and my mentor, Naveen sir, for giving us the opportunity and for teaching us and making our concepts clear every day. Thank you, sir. And next, I would like to thank Femta madam and Jyoti ma'am for their inputs. And next, I would like to thank Anila also for moderating and for conducting the session so well. And of course, our IAP Kerala State President, Shimmi sir, and our Trivandrum President, Hari Prasad sir, for joining. And last but definitely not the, and Shobha madam for madam's valuable inputs. And yeah, last but not the least, I would like to thank all the audience for the patient listening. Thank you.
Thank you, Benu dear.
Thank you, sir.
Thank you.